Hello everyone, my name is Jessica Breezy and I am a nurse practitioner working in the Stroke Prevention Clinic at the Royal Victoria Regional Health Centre. This 7-minute video will use 3 case studies to demonstrate appropriate utilization of the revised Stroke Prevention Clinic referral form. For a complete overview of the form, please refer back to the overview vignette available on the Central East Stroke Network website. It is recommended that you download a copy of the form to follow along as we walk through the cases. The link is available in the invitation email and the Central East Stroke Network website. For our first case, we have a 56-year-old man who was sitting at the dinner table and was trying to put a piece of bread in his mouth when his wife noticed that he missed his mouth entirely. She then noted a right facial droop and garbled speech. She called 911 immediately. The patient was assessed in the emergency department and was found to have a right facial droop, right arm and leg weakness, dysarthria, and expressive aphasia. His symptoms resolved within an hour of being in the emergency department. Based on the patient's symptoms, which risk category would you select? Which investigations would you complete? What if the CT angiogram revealed a left carotid stenosis estimated at 55%? Which antithrombotic would you order and what dosing? What education would you provide the patient and family? Based on our patient's symptoms of right arm and leg weakness and a right facial droop and speech difficulty, we've clicked the relevant symptoms, which would put our patient at the highest or increased risk patient category. We have indicated the date and time of onset and have utilized this as a checklist and clicking off the relevant diagnostic investigations. We completed a CT head, a CT angiogram, which is preferred over a carotid Doppler as the patient had no contraindications to a CT angiogram, a 12-lead ECG, and stat blood work. A validated swallowing screen was not completed at this time because the patient's symptoms had completely resolved. Because the patient had a carotid stenosis of 55%, we referred the patient to a vascular surgeon and have indicated that on the form. After we reviewed the CT scan and there was no evidence of bleed, we went on to prescribe a bolus dosing of aspirin and advised the patient to resume with daily dosing of 81 milligrams once they returned home the following day. We advised the patient not to drive until medically cleared by a physician. We reviewed the signs of stroke and advised the patient to call 911 immediately for any worsening or continued signs. And we provided the patient with some written discharge information to review upon arrival home. For our second case, we have a 78-year-old woman who was admitted to the hospital with a left frontal temporal parietal stroke after presenting with symptoms of right hemiparesis and global aphasia. The likely etiology was embolic as she was newly diagnosed with atrial fibrillation. She received rehabilitation as an inpatient and was discharged home with improved but persistent deficits and a script for apixaban 5 milligrams twice daily. Which risk category would you select, and what information should accompany the referral? Because this patient was admitted to hospital and likely had all of her investigations completed, she was triaged as, she was selected as a lower risk patient despite presenting with higher risk symptoms. A validated swallowing screen would have been completed as an inpatient, and she would have been followed by a speech-language pathologist. In order to help prioritize the referral, we would send along any consultation reports and diagnostic investigations that are listed here. We have also indicated that we have started apixaban 5 milligrams twice a day. For our final case, we have an 83-year-old gentleman who presented to the emergency department with a sudden onset of dizziness. On further questioning, he explained that the room felt like it was spinning. He also had nausea and double vision that also lasted for 5 hours. There was no ataxia or gait disturbances noted in the emergency department. He denied any previous history of vertigo and stated that positional changes did not seem to affect the dizziness. Based on this patient's symptoms, which category would you select? Which essential investigations would you complete? This patient's symptoms are suspicious of posterior circulation ischemia, and we have indicated that on the form. Because 2 of the boxes were selected, a CT angiogram would be appropriate in order to assess this vascular territory. The patient would accordingly be triaged at a higher risk. Again, we have indicated that we've started a bolus dosing of aspirin and advised the patient to resume with daily dosing of 81 milligrams. That concludes the case review for the Stroke Prevention Clinic referral form. For additional information on the practices that support this referral form, we advise you to consult the Canadian Stroke Best Practice Recommendations website with the hyperlinks provided.